Oh, good afternoon, everyone. Welcome to Suicide Society and the Human Experience. Tonight, we're going to have a presentation by Dr. Donna Holland Barnes, who is the founder and CEO of DHB Wellness and Associates, LLC, where she conducts life coaching, grief recovery, and suicidal prevention training on suicide risk. And she's also the co-founder and president of the National Organization for People of Color. Um, um, and this organization was founded in 1998. Dr. Barnes is on the faculty at Howard University School of Medicine. She has published in the area, and she's also been on NPR, CNN, and other media outlets. And on a personal note, Dr. Barnes and I met in the 70s, and we were hanging out for a while with friends and then connected again around our work on suicide in the Black church about 6 or 7 years ago. So I'm going to stop right there with the introduction, and anything else that Dr. Barnes would like to share about herself, I'm going to hand it off to her.
Thank you.
And I'm supposed to say this is being recorded. Now I'm handing it off.
Okay, thank you, Dr. Outlaw. It's a pleasure to work with you again. And of course, after meeting you 5 or 6 years ago, we've kept in touch, and that's very good. I am considered a suicidologist because all my work is in suicide prevention and intervention. I've been doing this since the late 90s because I lost my son to suicide in the early 90s. And at that time, I just did not know how to handle it, what to do. I was applying to law schools at the time, and then I just needed to know more about suicide. And so that's the beginning of me reading everything I could on suicide and then just making it my life. And this gives me a way of his death not being in vain. So it is my objective to make sure everybody has a clear understanding of suicide, how it affects society, and how it affects us as human beings. And if we can at least get training done as often as we can so that people understand how to recognize the signs when someone's in a suicidal crisis, that would be good. I've been at Howard University now since 2002 in the Department of Psychiatry, teaching the third-year medical students on how to manage a suicidal patient. And so Dr. Outlaw had asked me to come and share some of the things that I talk with the medical students about. So I understand that people in the room are in training to become professional nurses, psychiatric nurses, etc. And of course, nurses are almost the first responders, even more so than the doctors. So it's important that you are able to detect when someone's in a suicidal crisis, because studies have shown that the majority of your completed suicides have seen a physician 30 days prior for whatever reason. And if we cannot detect when someone's in a suicidal crisis, we're going to continue losing people. People don't necessarily let you know that they're thinking of suicide, because if you don't ask them, they're not going to tell you, the majority of them. I did a study in the emergency department at Howard University about maybe 5 years ago, and I got some medical students together, and we stayed in the emergency room for 3 straight days, assessing those who came through the emergency room for whatever couldn't be for suicide. It had to be for something else. And we tested them. We screened them. That's the word I'm looking for. We screened them for suicide and suicidal behavior. And out of maybe 122 patients that we were able to interview at the time, 7% of them were actually suicidal, and 3% were literally admitted into the psych ward. Now, we would have never been able to know that if we hadn't screened them. So the whole point, and I ultimately ended up publishing a paper on that with some other colleagues who were doing the same testing at other emergency rooms across the country, Denver, Boston. And the whole purpose of the study was to insist that people screen for suicide at all times. As nurses, you're going to be screening for weight, blood pressure, all these different things, temperature, and you give people a number when they leave. Well, this is your weight, this is your blood pressure, this is that. Never for suicide. We don't screen for it because it's hard to measure. There's not really a number. We can only go by what you tell us. So if all emergency rooms, all doctor's office, whether they come in to visit for a broken toe, if people are screening for suicide at all times, like you are for your hypertension, that would be a good thing. Okay, with that being said, let's move on. So I'm going to talk about, actually I'm not going to talk about, well, I will, prevalence of suicide, meaning how the rates are in various parts of the country. Then we're going to talk about predictable patterns, supportable influences, and preventive measures, even without all the answers. Okay. The prevalence of suicide, I think most of you already know that in the year of 2018, we lost 48,344 people to suicide. And we only know 2018. We don't have 2019 yet. We'll probably get that in another month because the rates of suicide across the country come from the Centers for Disease Control, and it takes them at least 2 years to collect all that information, all the death certificates from all the 51 states. So 2018, we lost over 48,000. When I first got into this business in the mid-1990s, we had lost maybe 28,000. And it's been going up every year, up and up and up. Never has it gone down or was flat in all of those years. Suicide is the only death that has increased substantially, never gone down, never became flat. Why is suicide the only thing that we have a problem with preventing? We have a lot of studies on cancer, heart attack, strokes, and we can prevent that with all of the studies that are out there. We have a lot of papers that are published, clinical trials, studies, but we can't seem to put our finger on it. Something we're doing that's not right. Something we are doing that's causing people to kill themselves no matter what. So maybe we can talk about what some of the things we are not doing, because we keep being real bad at detecting suicide. Why is it 48,000 now in 2018 when we have all these tools, all these prevention measures, all this training? All right. If we look at the definition of a mental disorder, because most people want to correlate suicide to a mental disorder, and it isn't. I think that's one of the mistakes that we make. We always want to assume that someone is suffering from anxiety, suffering from depression, suffering from bipolar, schizophrenia, anything. So when someone is in a suicidal crisis and they go to a doctor, the first thing they want to do is talk about a mental disorder. And then they want to prescribe medication. And then they send them home. When they come back, how's the medication working? Never, ever, ever is there really a discussion on suicide as an option. What's going on in your life where death seems to be an option? It's a behavior. We need to really deal with that. And if I were to tell you that how to actually deal with it from a point-by-point basis when you have a suicidal patient in front of you, one of the things you want to do is nix the mental disorder. Don't even talk about that. For the first 2 weeks, talk about suicide as an option, as a behavior. Why is death an option? What's going on with you? Now, if you want to discuss, depression, anxiety, or any of the other mental disorders, you can do that, but concentrate on the fact for 2 weeks on the fact that they are looking at suicide as an option, because you don't have to have a mental disorder to be suicidal. You really don't. But in this country, suicide is a symptom of a mental disorder. And that's unfortunate. Maybe that's what we're doing wrong. Maybe that's why the rates keep going up. So when you look at the definition of a mental disorder, in the DSM-5, it talks about socially deviant behavior and conflicts that are primarily between the individual and society are not mental disorders. They're not mental disorders. And suicide is looked at as a socially deviant behavior and a conflict. So, are these factors what you would settle for as predictable patterns? Because we think if we can predict that they're going to probably take their own life, then we can save them. Any stressful negative event in one's life coupled with aggressiveness, impulsivity, prior attempts, substance abuse, or any other addictive behavior, anguish, and a psych ache. Psych ache is an emotional pain, which is what most suicidal people are going through, emotional pain. All they really want is the pain to go away. And much of this stuff you already know. So are these factors what you would settle for as predictable patterns? Is this what we're going to look at? And if any of this is not present, then we're going to think that they're safe. We need to not go by lists, because you can have somebody in front of you who is thinking of taking their own life, who are not aggressive, not impulsive, never had a prior attempt, didn't have any addictive behavior, was not angry, and was not suffering from a psych ache. Now, some of these things are prevalent, and we do need to definitely control for suicide prevention when aggressiveness and impulsivity especially are present, but not always. Influences that are support systems. You want to make sure that your patient has strong family ties, strong coping skills, resiliency, spirituality, social support. We need to really identify those support systems, because we have a tendency to look at nothing but risk factors. Well, let's figure out what the risk factors are. Support systems override risk factors. You can have 7 or 8 risk factors in one good support system. Concentrate on that one good support system. Paying attention to the risk factors doesn't really get us anywhere. We have to pay attention to the support system. So in any sort of disease, which you have learned in nursing, is that you look at the normal steps of any disease, the course, the core factors, the significance, the context, and the coping, so that you can sort of have a pattern of the disease and track the disease. Is it low, moderate, imminent? So with suicide, do the same thing. You want to look at the course. How long? When is the last time you had thoughts of suicide? Core factors. What's the frequency? Method, plan, Significance. Has thoughts of suicide affected your everyday life and relationships? Context. What happened? What was that a triggering event? And then coping. What is keeping you alive today? And that's pretty important, especially the context. You take a glass of water, you fill it up to the very top, and that one drop causes it to overflow. That's like what the triggering event is. And we don't pay enough attention to the triggering event. People can be hopping and skipping along doing okay, even though they're vulnerable or they're sad, but sometimes a triggering event will cause them to go overboard. Because when you are thinking of suicide, you got a living side and a dying side, a living side and a dying side. Everything that you want to do on the living side is planning, doing what you normally do. And then all of a sudden, you're speaking to that dying side. Something happens to support the dying side, and then that's it. That's it. We have negative thoughts and positive thoughts all the time, and sometimes the negative thoughts override the power, the positive thoughts. Sometimes I think if people could just have gotten through the night, they'd be with us today. Coping is so important. What is keeping you alive? Sometimes I'll say to people who are thinking of suicide, I'll say, well, why are you here today? In other words, what I'm asking them is, why didn't they do it last night? They're in front of me because something is keeping them alive. Nobody really wants to die. Most people do want to live. And they tell you because they want to live. They want you to save them. Some people will not tell you, which is like we were doing the study in the emergency room. They will not tell you because they don't want anybody to stop them. Even though they may still want to live, they're just so down and out that they don't want anybody to stop them. And studies have shown that when you do interfere, they realize that I'm glad somebody interfered. I'm glad I'm alive today. There was a study on the Golden Gate Bridge. When people jump off the Golden Gate Bridge, it's a 250-foot drop. It takes about 9 seconds. And in those 9 seconds, there's a lot of thoughts that go into the mind. There were people who miraculously survived and were interviewed. And when they were interviewed, they told the interviewer that they were very happy that they didn't succeed. Because during those 9 seconds, they were thinking about, oh my God, I made a mistake. One guy had just put his hands out so that he could break the fall. Another woman kept saying, I hope I live, I hope I live, I hope I live, all the way down. People will do it just to be doing something, but then at the last minute change their mind. Many people who have attempted and gotten through the attempt, came out of the coma, are so glad that they came out of the coma. People do not want to die. They just want the pain to go away. I'm going to give you okay. You are assigned to the ER. Think of yourself as being assigned to the ER. A person who attempted suicide is presented by a family member and placed in a waiting area after they had been triaged. You are told to speak with the client to determine their severity of the suicide attempt. Now, many of you have worked in ER departments, and the triage is really important because I know at a lot of ERs, waiting and waiting and waiting can be a problem. Some patients just run out of the emergency room because they've been waiting too long. So if someone is triaged and they're in the waiting room, it gives you an opportunity to talk to them. Some of the things you want to talk to them about is what did their past 48 hours look like? You know, you want to have a specific sequence of asking questions about suicide. You want to determine how serious was the current action taken, how serious was the client's intention, was the attempt well planned or an impulsive act? Did alcohol or drugs play a role in the attempt? What was the specific stressor, a set of stressors that prompted the attempt? What was that triggering event? Use behavioral incident questions to create a verbal picture because you want to be clear. You want to be clear on why this person is in the emergency room from a suicide attempt. So you want to ask really specific questions. What was going on in the past 48 hours? You know, and when you ask these questions, of course, you know, but I'm going to say it anyway. When you ask these questions, you want to really be quiet and listen. You don't want to try to come up with solutions. They're not there for that. Just listen to what they have to say. Have a specific sequence of asking questions about suicide. Past 2 months, you want to know what they did in the 48 hours. Then after you finish that, you want to know what they did in the past 2 months. You want to determine how much time the client has spent thinking, practicing, preparing for current attempts. Use gentle assumptions, denial of the specific, and behavior incident questions for each method that is uncovered. I have a client now that I talk with frequently because she is thinking of suicide. She's in another country, so I can't really get to her, but I do talk with her. And I just ask her. In fact, I had a conversation with her this morning, and I asked her when's the last time she thought of suicide, and she said 2 days ago. And it's something when you're dealing with a suicidal patient, don't ask them, have you thought of suicide in the past week? Assume that they have and say, how often did you think of it this week? And so when I put it that way, they actually answer it. She says, well, the last time I really thought about it was Saturday. And she said she thinks about it every day, but strongly it was Saturday. So gentle assumptions, how often do you do it? How often do you think of it? And I know I'm throwing a lot at you. Suicide is such a big topic. And when you're given an hour, that's good. I'll try to get as much as I can in an hour. And there's so much more I could say on each slide, but I don't have that much time. To be honest with you, when I work with residents, psychiatric residents at Howard, I usually do a 12-week seminar, and I work with them for 12 weeks for an hour every Friday when they have, that time off. Okay, so here's a quick quiz. So you need to determine the risk, either no risk, low, moderate, or imminent. So age 38, married, white male, 2 children, diagnosed with bipolar, 2. Currently complains of anxiety and restlessness, impulsivity, and depressive symptoms. Notably, decreased energy and drive. Scores are moderately depressed on the BDI. Denies suicide ideation, but admits to brief, fleeting thoughts of negativity affecting others, that they would be better off without me. No history of suicide attempts. So I want you to think about that, unmute, and tell me, what do you think? Low, moderate, imminent? I'll give you a few minutes to think about that.
I would definitely say moderate.
Moderate, okay.
Yes.
Does everyone agree with that? Does anyone think it's different? Low, moderate, imminent?
I would agree that he's moderate as well. He does have some protective factors where he has the family, and he also talks about he has protective factors, but he also has risk factors where he says they'll be better off without him, and the risk factors of the impulsivity and the depressive symptoms. So he's kind of moderate to me.
Okay, good. Anyone else? One more person.
I would want to say imminent because of the fact that the fact that he is saying that the world would be better without him. I would keep a close eye on him for at least the next 24 hours.
Excellent. Okay, so you're looking at some things by what he's saying, because that is one of the um, reasons given when people take their own life is fearlessness, feeling like they're a burden, etc., etc. And feeling like they're a burden is number one in some of the studies. Impulsivity is important. Um, depressive symptoms, we all have those from time to time. The answer to this is there is no specific answer. The reason why I'm asking you this is because some people have different opinions. When you ever have a suicidal patient and you're trying to figure out whether to admit them, don't figure that out on yourself. You take, or alone, I'm sorry, you have a consult. It should be a team of people when you're dealing with someone who is suicidal. So together you can determine if it's low, moderate, or imminent. And you saw that 2 people thought it was moderate and 1 thought it was imminent. So there is various thoughts and ideas on this. Because it's such a sort of a critical topic and a critical experience that you're going through with your client, you really need to have more than one person make that decision. Okay, good, thank you.
Great point.
So imminent, you know what that is, very likely, moderate is possibly, and low is unlikely. Let's do one more. Age 20, single white male, dysthymia and anxiety, diagnosed with dysthymia and anxiety, complains of insomnia, depressive symptoms, feeling trapped and hopeless, is troubled by as yet undiagnosed neurological problems, involuntary movement, admits to fleeting thoughts that heaven sounds good to me. I could never hurt myself. I do not want to be on earth, but would not take any actions to get there. Has no suicide plan. 2 years earlier, he was seen in the ED for an overdose. He mistakenly took twice the prescribed amount of pain medication for a knee injury. What do you think about this 20-year-old?
I would think he had a chronic suicidal tendency, but the fact that he said he would never be able to hurt himself, that, the one time he took the overdose was accidental, but definitely I will certainly work with him to kind of come up with some contingency plan that when he does feel that life is not worth living at that point, what is he going to do about it? And he doesn't have any weapon or anything like that at home, but the only thing is, like you say, is his medication. So hopefully whoever prescribed for him don't give him a lot of refill. I would just definitely monitor the medication that he's on.
Okay, good, excellent. So when you say keep an eye on him, Cecilia, what are some of the things you would do?
I would definitely ask him that what kind of support system he had at home. And does he have somebody that he can talk to? Or that, when he gets this way, what does he usually do besides get in touch with me? Because sometimes, you're not available 24/7. So,
Right.
and so that I want to be able to have he has some tool in his toolbox that he can do. I will give him some crisis hotline that he can call. So, and then also find out, was there anybody in his household that, he feel close to that he can talk to, or friends for that matter, and take it from there. Besides me, who else does he have in his healthcare system that he
Right.
do communicate within the team? Does everybody know that he had this chronic problem?
Right. And then you ask permission if you can contact them.
Correct.
Now, the other thing, you mentioned something about you're not available 24/7. No, you're not. But, excuse me, what What we can do is say to them, because this is what I usually do, I say to them, I want to hear from you every day for 2 weeks. Every day. Just text me, email me, leave me a voicemail, but I need to hear from you every day. Because you think there's a possibility that he might do something impulsive as a 20-year-old and possibly, you know, ultimately take their own life. So just ask them if they can contact you on a daily basis. It doesn't have to be a phone call or a visit. It can be a text, voicemail, or an email. Very good. Thank you, Cecilia. Anyone else want to comment on this?
Sorry, I would also add in there, if he has any goals, there's no future-oriented thoughts in this description of the patient. Like, is he in school? Does he work? Does he have any, like she was saying, does he have any family or any resources available to him besides him dealing with whatever's going on with his neurological problem? So does he have anything to take his mind off of the problems he's dealing with? What does he do in his free time? So addressing some of those issues.
That's an excellent point, because usually when people are really serious about thinking suicide, they have no thought for the future. They have no thought for next week or the next day, because they know they're going to take their own life. So asking them about what are their plans for the future, just what are your plans for tomorrow? What are your plans for next week? That's an excellent question, statement question to ask, is what are their plans? And usually when someone is suicidal, they're very negative. They're very, very negative about the world, about their community, about where they live. Everything is negative. So sometimes I'll ask them, what do they think about the world? What do you think about society? What do you think about your community? And is there anything, I'm trying to find out, is there anything that they're thinking positive of? And then I hone in on that. So
I would like
asking, okay, Portia, go ahead.
Yeah, let me make a comment. I was just also thinking, he has a neurological problem. And generally, you have so many community support groups of individuals that do have neurological problems, and that may be somewhat beneficial to that.
That's a good point. That's a good point, because maybe he's having problems living with that neurological problem. And finding a support group for them for any particular issue that they have is an excellent problem. To me, so support groups are a good alternative for face-to-face treatment with your physician. So yes, getting them any kind of support that they need, and again, getting their plans for the future. Any other thought before I go to the next screen?
One thing that you mentioned was that a lot of suicidal patients are negative. In my practice, I've seen people die by suicide who had a negative disposition, but also those who had a rather jovial disposition too. So I think that it's important to just always be screening everyone, not just those who may seem happy.
Excellent point, because I think what you're saying is that people mask their feelings, and many times, yeah, many times they're jovial, but they're masking it. Kids do that a lot, only because that's how they were trained. Kids know that when something's going on with their parents and they ask them, what's wrong, Ma, or what's wrong, Dad, they say nothing, everything is fine, but they can see it all over their face that something is wrong. So kids are taught at a very early age to mask their feelings. And so this is something that's really normal among people. How are you doing? Fine, when they're not really doing fine. We are taught how to go in the room and cry. Don't sit here and cry. If you're upset, go in your room. So, we're not trained to, are socialized to express our feelings. We are trained or socialized to cover them up and mask them. So that's a very good point. Thank you. All right. So generally, when suicide is coupled with particular circumstances and conditions, there are four things that come into play. Maybe this is why we're so bad at it, because we think that we have all the answers, we can stop them, but we never know when these four things are going to line up like lucky sevens. Impulsivity, vulnerability, fearlessness, and lethal means. When those four things line up, pretty much suicide is an option. But we never know when they're going to get to that point. They can be in front of you. They can say they're fine, I'm good, thank you, doc. Go out into the parking lot, go home, and shoot themselves. And you often wonder, well, what happened? I pulled out all the stops. What happened? What did I do? Well, you don't know what happened. Some thought process came into play. So if we can control the lethal means, that's a good help, because all four of these things have to be present. If you don't have a lethal means, there's a chance you lie down until the feeling passes. Now, many people think if you really want to kill yourself, you'll find another means. Not necessarily so. If it's in your mind to shoot yourself, because you know that that's really how it's going to be, and you know that's going to be more effective than anything else, and they don't have a gun, then they'll wait until they get a hold of one. Fearlessness, you can have lethal means, impulsivity, vulnerability, but be afraid to die. You can have lethal means, fearlessness, vulnerability, but not the impulse. You can have impulse, lethal means, fearlessness, but you're not vulnerable. You're good. But when all those four things are involved, it's very hard for us to prevent suicide, because we don't know when someone's going to get to that point. We really don't, which is maybe why we're so bad at preventing suicide. We don't know when people are going to get there. There's a poet, what was her name? She was in Boston back in the 60s, a very famous poet, not Sylvia Plath, but her friend, who was thinking of suicide since the 20s, since she was in her 20s. And she thought about it often, and in fact, she carried a bottle of barbiturates in her purse so that she'll be ready whenever she got to that point. She ultimately ended up living until she was in her 40s, but that day came when she had a means, she was fearless, she was vulnerable, and she was ready to go, impulsive. Her plan was not to shoot herself, because that was too messy. Her plan was to take and inject pills, an overdose. She ultimately did not do the overdose. What she did was she got in her car. At that time, this was before catalytic conversions, and she closed her garage and started her car, and she was dead in 15 minutes. She did it. She wanted to do it in some sort of a peaceful way. And probably throughout those years when she was living, she found out that some pills are not as effective as we think they might be. Okay. Studies have shown that a suicide attempt or death is highest within the first how many days of discharge? Anybody?
I would say 10 day, take a guess.
Okay.
It's 30.
30.
30.
30. Exactly, because I mentioned it earlier. 30 days. Because of that, it really sort of makes our antennas go up that people need to be screened for suicide at all times, no matter what they come in for. Okay, so let's talk about caring for adult patients with suicide risk. Once a patient is released from the emergency room, a secondary screening tool is needed. A secondary screening tool, once they leave, and you all probably already have one, but it helps the clinician to transition into the topic of suicide, more specifically once suicide risk is established. You can establish lethal means accessibility. You can determine if the client will be honest with the clinician. Because if the client isn't honest with the clinician, the client is not really working with you, there's nothing you can just say, look, there's nothing I can do. I can't work with this client, and completely dismiss them. So you want to have a relationship with the client so that they'll be honest. You know, you don't have to bristle when someone says they're thinking of suicide. It's nothing to bristle about. It's nothing to say, oh, I need to get you to the emergency room right quick. No, they're thinking about it. We had a resident at the mental health clinic at Howard said to him that he asked his patient if he was thinking about suicide. And his patient said yes. So then he started putting everything in order to get him admitted. And he said, Doc, what are you doing? And he says, well, I'm going to get you admitted to the emergency room. He said, you're thinking of suicide. He said, I just said I was thinking about it. I got to pick up my wife at 3:30. I'm going to visit my grandmother this weekend for Mother's Day. I don't want to be admitted. I don't have time. I just said I was thinking about it. He was a resident, so it made him nervous. And that's what he thought he needed to do. We don't need to get all upset thinking, oh my God, what am I going to do? I got to do something. Well, yeah, I'm sure that all of you already have something lined up in reference to when someone says they're suicidal, how to act on that. And then you want to determine if the patient will actually die by suicide. So the decision support tool, and there's a resource at the end of this presentation where you can find this decision support tool. This is what you should use in the ER. This is one of the suggestions. Transition question. You want to determine thoughts of carrying out the plan. Recently, have you been thinking of how you might kill yourself? Because sometimes when they're in the emergency room, they're still thinking about it. All they want to do is get out of there so they can do it. Suicide intent. Do you have any intention of killing yourself? Past suicide attempt. Have you ever tried to kill yourself? Significant mental health condition. Have you had treatment for mental health problems? Do you have mental health issues that affects your ability to do things in life? So these are some of the things you want to know. And then the last two questions, you want to talk about substance use disorder. Have you had 4 or 5 drinks in one sitting in the past month? Or have you used drugs or medication for non-medical reasons in the past month? Has drinking or drugs been been a problem for you? Then you want to find out about their irritability, agitation, and aggression. Recently, have you been feeling very anxious or agitated? Have you been having conflicts or getting into fights? Is there direct evidence of irritability, agitation, or aggression? Because usually that's when someone starts thinking of taking their own life. 15% of people who suffer from bipolar take their own life. They don't do it when they're in that depressed mode. They do it when they're in that manic state, when they're all anxious, irritable, and full of aggression. That's when they take their own life. Okay, so once a suicidal patient is discharged, there's a high probability they will attend their first outpatient appointment. True or false?
I say false.
That's false.
Absolutely. This is why follow-up is so important. We don't spend a lot of time with follow-up plans. Very few emergency departments have a really good follow-up plan. They should be followed up for at least a year afterwards. Okay, so this is just a little something. How much time do we have? I think we only have 15 minutes, so I'm not going to go through the rates by country. These are the resources that you have available for you. A consensus guide for emergency departments, a collaborative assessment and management of suicidality by David Jobs. Now, the CAMS program is a good program on how to manage a suicidal patient at risk without admitting them. That's the whole thing. You can do it outpatient. You don't have to admit them. And David Jobs talks about how you can do that without admitting them. And then the consensus guide for emergency departments is just a guide for you, which basically goes over the decision support tool that I had shown you. Because once you're out there and you're out in the field, you're going to have all kinds of tools suggested to you. You go on a website, you're going to have all kinds of things going at you. Sometimes you just got to follow your gut and do what you feel is right. Put your own tool together, because we are spending time following the leaders. Following the leaders. Maybe that's why the rates keep increasing, because following the leaders isn't working. So come up with something that you feel will work for your patient. And I know some of you already know that. Okay, that's it. So now I want to open it up to questions. Or discussion. Are there any questions in the chat?
Let's see.
I have a question
Okay.
for Dr. Barnes. My name's Janelle. I just wanted to know what you would recommend for practitioners who have lost patients to suicide. Is there a self-care protocol or some type of exercise or practice or something that you recommend to help with the emotional toll that may take on practitioners?
I don't have any kind of program at my fingertips, but there is a Dr. Michael Myers out of New York. He is doing that via Zoom. And if you Google Dr. Michael Myers, Myers, he has a support group for physicians who have lost someone to suicide, because that's a big issue, because it's not easy to get over the loss of a patient. So that's a good question, Janelle. Thank you.
Thank you.
I just want to say that I think that you're not the only one. To become a better practitioner that's part of the process. I'm not saying that we have to lose a patient for that. I think that, in my experience, that I had lost a patient too, but when I really kind of worked through that, the way I worked through that is I look back in the postmortem review with the team, looking at the pieces, what could we done differently. I think part of the problem was at that time, I was going on vacation, and as you say, the patient wasn't giving me all the info, that he was having so much trouble. He was just portraying what I want to hear. And then when the team was assigned that to another clinician that probably does not know him as much, and when he began to gave out all his beloved baseball card, I know, but she doesn't know. That would be a big thing for me to know that this is a warning sign. And so by the time I come back from the vacation in 1 week, it was too late. I mean, basically, he just drowned himself in the bathtub. So I think that for us is that you learn from it, so you're more acute with the process, and you share that with your colleague, because they will be a big support to you. And I don't know whether you're in a group practice or you have a treatment team, and I'm sure that you can get feedback, but it does not take away from the way how you feel. So I understand. I really do been through that. So just take care of yourself. Do mindfulness. All the tools you teach the patient, practice on yourself. So
Thank you, Cecilia.
Thank you.
That was very good. Janelle, is there anything else that you wanted to?
Additionally, can you just go through the process of I don't know who's a doctor on this call or not, so I just assume everyone
I'm
is.
not a doctor, I'm a nurse. So
Okay.
I think that nurses just, we take time to, I'm a nurse psychotherapist, I'm an advanced practice nurse, but I also teach. So I think that part of the thing is that I think that when working with suicidal patients, my process learning is that if you can engage with the patient, you address the boundary issue, you address what's important. In other words, when we talked earlier, that when I say that I wasn't 24 hours available with the patient. So the first session I have with them is that what do you do in crisis? When you can't reach for me, you 911 and all that, we address all that so that that the patient would know what to do. And I think that I still had a lot to learn. That's why I say every opportunity I have to learn, I learn. You just
Thank you,
become
Cecilia.
better.
Janelle, you want to finish your question?
Yes, Dr. Barnes, can you just give us a run through for people who haven't experienced a patient death like this, the process that happens? Because I don't know, it was a little bit jarring to me. I felt like all of a sudden I was being attacked, all my records were being reviewed. It seemed like can you just describe the process that happens after a patient dies by suicide and what we may anticipate?
You can anticipate a review of your records because a lawsuit is so imminent, because families, they need to have somebody to blame. And if they were in therapy, their first thing is they were in therapy. How did that happen? They don't have enough knowledge to not to blame you. So you always want to make sure, everybody wants to make sure they document everything, because if you don't document it, it didn't happen. You need to document everything. Well, I talked to Joe today. He said this, he said that, I offered this, I offered that. Document everything, all your conversations on suicide. You also, some people, and they're not that effective, but some people will have a suicide contract. In other words, sign this contract that you will contact me if you become suicidal. And they sign a contract. Now, of course, when they get to that moment at 2 o'clock in the morning, they're not going to say, oh man, I signed a contract, let me call Janelle. They're not going to do that. So it's not that effective, but it's good to have in your records. Well, they signed a suicide contract. I talked to them about this. I evaluated every time I saw them, that kind of thing. Most of the time when they review the records and they take you to court, I have never heard of somebody winning. Only time I've heard somebody winning is when they were at the medical center was actually at fault because they just didn't do what they were supposed to do. But yeah, that's going to happen, and it's nothing on you, nothing that you did wrong. It's just a process to make sure when the family comes at them, they have all their ducks in a row.
Thank you.
Now, the other thing is, if you lose a patient, please don't ignore the family. That's the biggest complaint I get when I work with families. I never heard from the doctor. The doctor never called me. Call the family. Call the family and say you're sorry to hear that I worked with Joe and da da da. I'm sorry that this happened. I did everything I could. But anyway, just call them to give your sympathies. You don't even have to say anything other than call and let them know that you're concerned. Then you can also offer them consultation for 90 days at no cost. That's a very nice gesture. Feel free to come and talk to me anytime you want. I can give you 90 days at no cost because I really am sorry for what you're going through. They're not going to sue somebody that's very nice to them. They usually come at you when you ignore them. Every parent, every family that I have talked to that have taken a physician or a mental health clinic to court was because they were being ignored. So you don't want to ignore them.
Thank you.
Thank you for the question, Janelle.
Dr. Barnes, can I offer another, I don't know if it's a suggestion or a statement, but also like Janelle was saying that a way for it to help her process when she lost a patient is also for you as the provider to have someone else that you can talk to impartially about what you experience as a provider. Because, you know, talking to patients about the things they go through and the things in their life, it can weigh on you as well. So having your own therapist or your own fellow provider that you communicate with, someone to help process what you go through every day, so that when you're saying, oh, I have this patient and I really think he's close and I'm having trouble, so you can communicate some of your difficult I guess cases with, not necessarily violating HIPAA, but someone that you bounce issues off of with. That makes sense?
Absolutely. Thank you, Melissa. Thank you for your comments. You've all given such great comments. Thank you, Melissa, Cecilia, Janelle, and all of the other people, Portia, that have made comments and had questions. And I really am honored to come and speak to you. I know it was just an hour and there's so much more to talk about in reference to suicide. Before I leave, is there any one more question that anyone wants to ask before I go? Okay, Dr. Outlaw, I
Well,
think.
I was going to just say one more thing, Donna, that was connected to, I think the question that both Janelle and Melissa, because I think they're interconnected. Melissa's question was about wellness for the provider, especially the provider who has been providing treatment for someone who dies by suicide. So that's the one thing, and I think you did a great job of talking about that. But are there some other specific self-care things that you can suggest to people?
No, not other than what Melissa had mentioned, to keep it ongoing. Always stay in check. Not only when you lose someone, but just to, for a mental health checkup, if you will, just to make sure you're doing what you need to do. It's always good for everybody to have mental health checkups. So like Melissa was saying, if it's ongoing and you do it on a regular basis, that would be a good
Okay,
I,
and I'm
I
sorry.
was I was going to just suggest some couple of simple things that I do myself. If you enjoy music, I actually make a tape for myself called Happy Music, so that when I'm sad, like I would just listen to that, or exercise, take a walk.
Right.
When you get too focused on it, because we do get burnout, and
So what I hear you saying, Cecilia, is that each person has to identify for themselves what
what
their
work for them.
what specific self-care thing that works for them. For some of us it might be exercising, it's for some of us it might be eating chocolate cake, who knows, but it's that self-care thing that you need to apply that works for you. Well, thank you, Dr. Barnes. This has been really enlightening, and I'm trying to look in the chat box. I see a lot of thank yous in the chat box from people, but I don't see another question. I see good discussion and information. So thank you so much for this presentation. And you know what? We are right on time with ending, which people also appreciate. They appreciate wonderful, wonderful information given in a really interactive way. I thank you so much for that, but they also appreciate getting done on time. So thank you again so much. And we look forward to hearing from you again sometimes. Thank you.